A 35-year-old female presented with abdominal pain and vomiting. I am showing you her plain abdominal radiograph. Describe the findings.
Okay, assessing the provided imaging. The radiograph demonstrates multiple dilated gas-filled loops of small bowel in the central abdomen, measuring greater than 3 centimeters in diameter. There is a complete absence of gas within the colon, and surgical clips are visible in the right side of the pelvis and the right upper quadrant.
What is the most likely diagnosis, and what are the main differentials for this appearance?
In that case, the most likely diagnosis is mechanical small bowel obstruction secondary to post-surgical adhesions. Main differentials for mechanical small bowel obstruction include incarcerated abdominal wall or groin hernias, Gallstone ileus, primary small bowel or caecal malignancy, and Intussusception or Volvulus.
I am now showing you 2 abdominal radiographs from other patients presenting with suspected bowel obstruction. Describe their specific signs and explain why these variations occur.
Well, the first radiograph demonstrates the string of beads sign, which represents small pockets of gas trapped between the valvulae conaventes in fluid-filled obstructed loops. The second radiograph shows a gasless abdomen, representing complete fluid filling of the obstructed small bowel loops, with a total absence of gas.
I am showing you another abdominal film. How do you distinguish dilated small bowel from large bowel on plain radiographs?
Okay. Small bowel loops are centrally located, have a diameter less than 5 centimeters, and feature valvulae conaventes that cross the entire lumen. In contrast, large bowel loops are peripheral, have haustra that do not traverse the full lumen width, can exceed 5 centimeters in diameter, and often contain solid feces.
I am now showing you a pelvis radiograph and a coronal CT scan from another patient. What anatomical line must you check to exclude a groin hernia, and what do these images demonstrate?
We must inspect the groin below the inguinal ligament, represented by a line from the pubic tubercle to the anterior superior iliac spine. These images demonstrate small bowel loops herniating below the inguinal ligament on the right, confirming an incarcerated right-sided inguinal hernia.
Now, compare those findings with this axial CT scan from a patient with a history of hernia repair. What does it show?
In contrast, large bowel loops are peripheral, have haustra that do not traverse the full lumen width, can exceed 6 centimeters in diameter, and often contain solid feces.
I am showing you a final axial CT slice. What critical complications must a radiologist check for in this setting?
In that case, we must evaluate for bowel strangulation and ischemia. Key CT findings to check include bowel wall thickening, abnormal or reduced wall enhancement, mesenteric fluid or venous gas, and pneumoperitoneum or pneumatosis intestinalis indicating perforation.
These images demonstrate small bowel loops herniating below the inguinal ligament on the right and left, confirming a possible incarcerated inguinal hernia.
Well, mechanical small bowel obstruction is a surgical emergency. I would immediately contact the referring surgical team to report the findings and recommend an urgent contrast-enhanced CT of the abdomen and pelvis to identify the transition point, locate the obstructing cause, and exclude bowel ischemia or strangulation.